This is Michael Smith of MedPage Today. I'm in Toronto at the annual meeting of the American Academy of Neurology, where the buzz in the corridors has been about a potential new therapy for multiple sclerosis. The theory is that one of the factors involved in the pathogenesis of the disease is, in fact, a vascular obstruction in the veins leading from the brain. Why this has caused such an uproar, such an explosion of interest, is that offers an immediate possibility for surgical intervention that might affect the symptoms of the disease. I'm here with the gentleman who's at the center of this firestorm, Dr. Paolo Zamboni of the University of Ferrara. Dr. Zamboni, welcome to MedPage Today.
Good morning. Good morning to everybody. Yes, I described the association between a condition called CCSVI, this chronic cerebrospinal venous insufficiency, that is caused by malformed valve and obstruction, likely of malformative origin, in the jugular and the diagonal vein. And this condition, of course, impairs the venous drainage of the central nervous system, so may potentially lead to iron deposition and also to a worsening clearance of viruses, opportunistic infection, cytokines and toxins coming from the main disease, the main neurological disease. So one suggestion was to treat in a pilot study, which was published last December, in which we demonstrate some advantages for patients with a better neurological outcome, and very interestingly, a better quality of life. That is, in a chronic disease like this is certainly one of the more difficult goals to achieve. This pilot study was very important since the regional government in Italy and also the Italian MS Society finally decided to support a randomized control trial in order to understand exactly the advantages of this additional tool in the fighting against multiple sclerosis.
But it's fair to say that at the moment, I think, Dr. Zamboni, that the work is still preliminary. You have a randomized controlled trial that you're starting. There's another pilot intervention study that's being started here in North America. What needs to be done? What questions need to be answered before you can say to multiple sclerosis patients and their physicians, yes, this works, or no, this doesn't work?
I think that in this particular study, we tried to reach a primary endpoint never reached. That is prevention of disability. Because till now, drug showed a very good effect, especially on MRI endpoints. So there was more action in terms of MRI endpoints with respect to clinical endpoints. So we want to focus more on clinical endpoint, adding also, of course, MRI measurement, without stopping and discontinuing the disease-modifying treatment that are in course. So CCSVI treatment is a coherent treatment by angioplasty of the CCSVI condition, in addition to immunomodulating treatment, because we do not know, again, at this point, mechanism related to autoimmune disease. So we maintain both treatment with a strong endpoint.
Mm-hmm. This is the study that you're starting in Italy?
Yes.
When will that report? How long is that going to take to do?
I think that next June probably we'll submit to the IRB the request of the study, and so we are ready to start next summer.
Okay. In the meantime, of course, patients, as you know, are clamoring for more information about this condition and the potential treatment. If a patient comes to a doctor and says, "Look, I have MS. Should I get tested for this condition?" Should the answer be yes or no at this point?
I think that the reply cannot be black and white. My recommendation is for people who have an MS condition with a good control on behalf of the treatment, I recommend to maintain the treatment and wait for the evidence through the trial in the next years. For people that are in a rapid decline, without any treatment, any effective treatment that can modify the disease course, I think that the neurologist who follow this patient may offer this treatment on a compassionate ground. I think that this is a proposal that I invite the neurologist to consider, because angioplasty is in the venous system is a treatment with low risk, is a safe treatment, and if the patient should not have, is desperate, because should not have any response to the treatment that are currently available, I think that this could be a good opportunity with a high chance to improve at least the quality of life.
The question, though, is whether people should get tested, and there is some difficulty of knowing what the right test is for CCSVI. MRI, venograms. Is it difficult to diagnose this condition?
Yes, because it's probably more difficult the diagnosis with respect to the treatment. Gold standard is catheter venography, but of course is an invasive technique. So we experimented the color Doppler examination with a special protocol that probably need of trained personnel, because it's completely new kind of investigation, although use current equipment for color Doppler examination. And we found a very good agreement by using this non-invasive screening technique. I know, for example, that there are centers in the United States that can be offered this. For example, in Georgetown University, there is a group of BBLE that know very well venous malformation and now is currently investigating people, for example. I do not recommend MRV because the cause of the narrowing are flap, membranous obstruction, septa, that cannot be detected by MRV. MRV presents a very good diagnostic accuracy in measuring the cross-sectional area, but it's different from an arterial stenosis, are intraluminal defect. So very teeny intraluminal defect that cannot be seen by MRV. So I discourage to use this kind of assessment because it can give false positive and false negative.
Right. So there are, in fact, still some obstacles even to getting the diagnosis. One of the questions that arises is many people who are on the medications for MS find that they are difficult to take. They're not pleasant medications, and naturally would like to stop them if they could. And some are saying, well, if this treatment's going to be available pretty soon, why shouldn't I just stop my medications and at least not have these side effects? What's your answer to that question?
Really, I do not know, because I treated patients that from the beginning did not use any treatment, with results similar to those achieved in patients taking treatment. But I do not have any evidence of the exact mechanism linked between CCSVI and MS and the autoimmune reaction. So I cannot answer honestly to this.
But if a patient came to you and said, "Doc, I have MS and I'm going to,"
I never discouraged a patient to the drug. Possibly they may use alternative drug.
I see.
But at this point, I cannot recommend to discontinue treatment.
I think that seems to be the consensus. There's no point jumping the gun on this. Dr. Zamboni, thank you very much for your time.
Thank you.
In Toronto, I'm Michael Smith, MedPage Today.